we would go on to our next speaker, Dr. Mahesh Kumar, who's the Chief of Neuro-Ophthalmology Services at Arvind Eye Care Systems at Madurai. And he's going to be talking on another important topic, infections of the visual pathway, the Indian scenario. On to you, Dr. Mahesh.
Good evening. And first, I would like to thank the chairman ARC and the other ARC team members for having invited me here. My topic is infections of the visual pathway. So I'll be dealing with it in infections of the optic nerve, chiasm, as well as retrochiasmal visual pathway. So in general, infections of the optic nerve were uncommon even in the pre-antibiotic era. Most were demyelinating or autoimmune disorders, as is the case now also. Occasionally, we had even infectious lesions in immunocompromised patients, or they could be para-infectious encephalitis causing optic neuropathies in post-viral syndromes. The clinical features of infective optic neuropathies were that of routine optic neuritis, as listed out in all these features, and the presentation also were variable, like acute or subacute, unilateral or bilateral, with a periocular discomfort. So the modes of invasion could be a localized invasion by a direct invasion or a contiguous spread from the adnexus of the pharynx and sinuses. Hematogenous spread can occur in viruses, bacteria, fungi, parasites, as well as spirochetes. So example one is an opportunistic infection. In case of virus, CME infection is one of the more common infections in the immunocompromised host, and secondary optic neuropathy from juxtapapillary CME retinitis is more common as a mode of infection of the optic nerve. In other instances, cryptococcal infection is more common in the CNS, which also can cause an anterior visual pathway in AIDS patients. Tuberculosis is one of the more common modes of infection of the optic nerve, and its manifestations could be neuroretinitis as well as optic neuropathy. It could be from contiguous spread from the choroid within, or it could be a hematogenous spread. Or a direct infection of the optic nerve, or a simple hypersensitivity reaction. You can see this choroidal tubercles here, as well as the optic nerve infiltration. In other instances, it can present as an optic nerve tubercle, such as this one, papillitis, papilledema secondary to raised intracranial pressure, or a retrobulbar neuritis. And neuroretinitis is a more common form of involvement of the optic nerve, as well as what has been described already, the opticochiasmatic arachnoiditis. Some case examples: a young female with severe headache and cerebellar signs. She had bilateral severe papilledema. Neuroimaging, a CT scan was done, which was several years ago, showed a ring enhancing lesion in the posterior fossa and the cerebellum, which caused early hydrocephalus, causing papilledema and neuro-ophthalmological presentation. Of course, these cases were referred to the neurologist for appropriate management. Next case is an young boy with a history of fever and headache. He had a family history of TB treated 3 years back. And for the present episode, he was treated with antibiotics and ATT and mannitol before he developed symptoms of meningitis. After resolution of the acute phase, he presented to us with the complaints of defective vision of both eyes. You can see the subnormal visual acuity in both eyes, and both the pupils were very sluggishly reacting because of bilaterality. And on presentation, the patient had this sort of temporal pallor because of the involvement of the papillomacular bundle. So this was a case of opticochiasmatic arachnoiditis. You can see the ring enhancing lesions in the opticochiasmatic region, which are grape-like clusters. And the important point to remember here is, along with antituberculous treatment, steroids also have to be given because it's primarily an immune mechanism which causes the vision loss. And so, in order to save the vision, we should be giving steroids also, and which will be preferentially done by the neurologist. These are some other manifestations, diffuse tuberculomas in the brain. Next case is a young female, 13-year-old girl with a defective vision both eyes of a 1 month duration. There are signs of meningitis with intermittent fever. Visual acuity in the right eye was 5/60. Here you can see a distinct feature. There is a bilateral papilledema. But then in addition, she had a manifestation of a neuroretinitis as well. So on neuroimaging, because of the bilateral papilledema, she showed a ring enhancing lesion in the parietal as well as the temporal lobe. There are some lesions in the chest as well. And this was a tuberculoma, large tuberculoma in the retrochiasmal region. Again, it was referred and treated appropriately. So in this instance, the patient had lots cervical lymph nodes, which was biopsied by the neurosurgeon, and it showed a macroscopic appearance, and you can see the cacheating necrosis in the central part of the region. Next is a young boy with double vision on looking down. So far, the first three cases, we're looking at an infection of tuberculosis. Next is a young boy with a double vision on looking down. And as you can see, there is a little hypertrophy on the left eye. And there is a downbeat nystagmus, which is, up gaze was normal. And neuroimaging showed a ring enhancing lesion again in the brainstem, in the midbrain, with an additional scolex, additional enhancing lesion as scolex, and neuro MRI was done in the same patient, of course, with the help of radiologists. We did a free scan and can see the scolex lesion in the midbrain. You can see in the sagittal section as well as in the coronal section. So here is a case of a neurocysticercosis presenting as an isolated case of midbrain cysticercosis, was referred to the neurologist and treated appropriately with anti-cysticercise treatment. Next case is a young male with presented with severe headache of 1 year duration and transient blurring of vision with a bilateral papilledema, which is causing the transient blurring of vision. So it's a case of a papilledema which needed a neuroimaging, and it showed a diffuse ring enhancing lesions similar to the previous one, but in addition, this patient had ring enhancing lesions in the brain. You can see these are all tiny cysticerci, which was causing hydrocephalus, and orbital imaging also showed cysticerci in the recti muscles, in the lateral rectus and the medial rectus here. So this is another manifestation of neurocysticercosis presenting to the ophthalmologist. So apart from TB and cysticercosis, there are some other infectious processes. A young 45-year-old female with a relatively good vision, but an ophthalmoplegia in the left side, painful with a proptosis. She is not a known diabetic. You can see here she had a ptosis with a edema, lid edema here. You can see some amount of restriction was there along with chemosis, indicating likely that it's an infectious process. You can see restriction of all ocular movements. And the first thing to be done is to estimate the blood sugar, which was detected to have high diabetes at presentation, and neuroimaging showed a filling defect in the cavernous sinus regions. Here you can see this filling defect as well as a dilated superior ophthalmic vein, all indicating venous stasis behind, and here dilated superior ophthalmic vein with engorged muscles, indicating likely cause of keratotic cavernous sinus thrombosis. It could be due to several causes like bacterial infections, or more commonly what we are seeing is mucormycosis, and appropriately they have to be treated with systemic antibiotics and antifungal. So this is a case of a mucormycosis where we have to see the palate also to make sure there are no necrotic patches, and these are some of the excised necrotic patches, photo courtesy by the ENT surgeon in Madurai, Dr. Rajinikanth. So finally, summarizing the COVID manifestations, there was no direct viral invasion has been proved so far, and isolated or neurological syndromes have been described, as was beautifully elucidated by Dr. Umapati, and mechanisms where post-viral inflammatory syndromes are primarily due to hypercoagulable syndromes. So the varieties of manifestations could be optic neuritis, a CVA, which is described. It can either be bilateral severe vision loss with visual field defects and other thrombotic occlusive events. Cranial nerve palsies has been described, as well as myasthenia. Nystagmus has been beautifully described by Dr. Umapati. Pupillary abnormalities have been described. And finally, the mucormycosis, which was rampant in our country during the second wave of COVID. Thank you very much for your kind attention.
Thank you very much, Dr. Mahesh. It was an amazing talk. Murli, can you just take one question before we go on to our next speakers?
Yes, Dr. Mahesh, thank you. I mean, what I wanted to ask you was, ethambutol optic neuropathy is also a bilateral optic neuropathy. So, I mean, would you, so many of these patients are on ethambutol. So I have two questions. One is, I mean, generally we presume it is ethambutol optic neuropathy. Would you consider neuroimaging to rule out any chiasmal involvement because of chiasmal or optic nerve involvement because of tuberculosis or the autoimmune process per se, or would you take it in the light of the entire clinical picture and visual fields? And point number two is in recurrent tuberculosis, in patients with a documented ethambutol toxicity, would you, because ethambutol is a very useful drug and a very cheap drug also, So would you consider reinstituting ethambutol whenever these patients have a recurrent tuberculosis? So these two questions to both you and Rohit sir for the comments.
Thank you, Dr. Murli. I would personally prefer to do a neuroimaging in all patients of suspected ethambutol toxicity, even though the chances of picking out something is very low, but we don't want to miss out that 1 or 2 patients. And number 2, if there is a documented recurrence of tuberculosis and ethambutol toxicity, like we would refer to the internist to consider alternate modes of therapy, and we definitely don't want to reinstitute ethambutol compromising the vision.
Very true. Thank you very much.